Today, I will talk to you about some of the work that we have, our most recent work we have been doing with infants at risk for autism. But for us, it's kind of like a more recent avenue. I hope to convince you that it's a very fruitful one. So we know that despite the advances in paper and pencil screening, as well as standardized instrument, autism, the age at which autism is diagnosed, it still hovers around 4 or 5 years of age, which is actually quite later than expert diagnosis can be made these days, which can be reliably. Okay, so let's see, is that good? Okay, so I was saying that typically children are still receiving a diagnosis around 4 or 5 years of age, although expert clinical diagnosis can be done earlier these days. And we also know that in disadvantaged community, that's unfortunately done typically even later. Now, in most instances, getting a diagnosis is the necessary condition before families can have access to services. So clearly, being able to identify the signs of autism in order to accelerate the process is key. But I hope to convince you that in addition to arriving at an early diagnosis, there is actually tremendous potential to really identify the earliest possible markers for risk. So why is that? Well, I mean, we all think about having risk for any kind of disorder as being a bad thing, but if you think about it, it can actually be a very positive thing. So we hope, the field hopes to basically, we aim to examine the neural basis of specific behavioral outcome earlier on, in order to understand the heterogeneity that we see in autism in developmental trajectories that may confer either resilience or increased vulnerability to the disorder, with the ultimate goal to improve outcome once risk is determined. So if we know that an infant is at risk for developing autism, we could and should start intervention before the onset of full-blown symptomatology. And ultimately, the hope is to actually prevent the full onset of the syndrome. Okay, so we want to study brain development or some of the earlier signs. I don't know that I will address the question that was asked as to whether autism you're born with, but I believe so. Most scientists believe that it's a developmental disorder with origin that may begin in uterus, but so there is a hope to identify very early signs. So how do we do that? Well, there is what's been termed the infant Sibs approach. Now, many of you know that the recurrence rate within families in community samples are about 10%. However, this rate, it's even higher in infant. There are about 20% in studies that focus on infants at high risk for autism due to having already a sibling in the family that has autism. And if we're talking about multiplex families, that is families where there are 2 children already with an autism diagnosis, the rate it's even higher. And for boys, it's almost 50%, it's 45%. So that's very high. So basically, this approach capitalizes on this increased risk, and it goes like this. We're going to follow infants who are born in families where there is already a child or more with autism, and we are then study them and ultimately arrive at a point where some of them will get a diagnosis, some of them will not, and by comparing their pattern, their developmental trajectories earlier, before they get a diagnosis, by comparing the 2 groups, the one that do get a diagnosis versus the one that don't, that as well in a sample of infants that do not have increased risk, we can hopefully identify some of the early signatures of the disorder. Now, this is an approach that is it's not new. It's been, I think, Marian Sigmund here at UCLA was actually one of the people who pioneered this, and we are at least in 3 rounds of NIH funding, each cycle lasting 5 years. So it's about at least 15 years that people have used this approach to begin to study to arrive at early identification, again, with the goal ultimately to ameliorate or even prevent the onset of full symptomatology. So a lot of the earlier work focused on behavioral markers of autism. So we figure we're going to look at early signs of what we know are impairments or deficits in the full symptoms. And I should say that there have been a number of atypicalities in the developmental trajectories of infants who later are found to have autism that can be detected. And these varies across a number of domains. They're not just in the social domains. You can also see motor deficits and repetitive behavior. So it's not just in one area or in the area that you would think is more relevant to autism. However, these differences have been typically observed in the second year. So when comparing the high-risk infants to the one that get diagnosis versus the one who do not. But the predictive validity of any of these single measure, it's still very, very low. And already in the second year of life, as I said, if you're looking at several different measures, we can start at least seeing red flags. But in the first year of life, I mean, that's even harder. And indeed, we found that the best predictors, if you're going farther down below 12 months, is actually evidence of altered developmental trajectory. And what I mean here is that you cannot just look at a behavior at one particular point in time. You need to look at this, for instance, the rate of change, or basically looking at how a child develops over a period of time. A few years ago, you might have recalled, there was a study that came out in Nature and that received, of course, a lot of attention. And I remember listening to CNN where they were saying, we can predict autism at 2 months of age. And I was going like, what? Really? I mean, I kind of knew the data. And in reality, if you are paying closer attention, or if you read the actual articles, you could see, here, let me get this, at the bottom, this is age in months. So what they found was that what this differentiated in red, the infants who develop autism from the low-risk control, it was the trajectories. So from 2 to 6 months, there wasn't an increase in fixation around the eyes, which is the normative pattern in the kids who later develop a diagnosis. So again, in the infants at high risk tended to focus more on the mouth, but this is what most typically developing infants do. So again, we can't just zoom in and look at what one single child does at a particular point in time and have a valid marker whether that child is indeed at an increased risk. So, our overarching aim when we launched this new program of research was to identify a typical brain development well before the diagnosis of autism is made. We want to identify atypicalities in brain function and connectivity that may precede, but that may underlie the impairments that we see in autism. And we want to use these results, our findings, to inform more developmentally appropriate and targeted interventions, and also potentially use, in addition to behavioral measures, some of this brain-based measure as outcome measures. So, how do we study the brain in very young babies or infants? There are several tools that we have available, but I'll just mention a couple that we are using in our project. And this is a very cute baby. They're undergoing an EEG as part of the studies that are headed by Dr. Shafali Jeste. And what does EEG allow us to do by recording from the scalp is basically to get a measure of brain functions that are very, very occurring and very rapidly. So it's complemented very well by the other measure that we use, which is magnetic resonance imaging during natural sleep. So here you see a cute little baby. It's actually almost a newborn, and as we prep them before we put them in the scanner, again, they are nicely asleep. We do not use any radiation. Obviously, MRI doesn't have any of that, but we are not sedating them either. So it's really a very non-invasive way to look at brain development. So we actually have in our study a fairly dense array of testing from 6 weeks, from 1.5 months, all the way to 36 months, although we really focused in the first year of life, because as I mentioned, that's the time where we still do not have any really super reliable markers, or even not super ones. So all participants come in for an MRI scan at 1.5 months and at 9 months. We use both some quote-unquote task-related, I'll tell you more about it, fMRI, as well as some resting state fMRI that allow us to tap into connectivity. And then they come in at 3, 6, 9, and 12 months for EEG and eye tracking. And then we also have a fairly dense clinical and behavioral assessment at 6 months, and then at 12 months, with some follow-up at 18 and 24 months before a full-blown diagnostic assessment is performed at age 36. And I must say that this is still work in progress, so there aren't too many kids in our, we're still, I would say about half of them still have to reach the 3 years milestone. But and I should not forget that all of these infants are also being genotyped. Sometimes we get saliva, sometimes they're okay with doing blood sampling. So we actually have an array of measures that we can use. What I am going to be focusing today, it's more on the MRI side, because that's my area of expertise. And if for those of you who may be coming back next year, I hope that Dr. Shafali-Jeste will be here to tell you the other side of the story about the very interesting findings she has with EEG. Okay, so before I move on into our study, I just want to give you some context for the research that has been done in the field before. So this is actually the first study that was done with MRI, following up children that ultimately received a diagnosis of autism versus control from about 18 months of age all the way to 5 years of age. And as you can tell, there are significant differences. The autism group is always in red for reason that escapes me, and then the normal control curve is in blue. Not every single child had scans at all of these ages, but I hope you can see that despite the significant group differences, there is tremendous variability across the samples, right? There is quite a bit of overlap. And this was the case both when you're looking at total cerebral brain volume, but also when you're looking at just the gray matter and the white matter as seen over here. So as important it is to actually find some neural correlates for the finding that mirrors the findings of an enlarged brain head circumference. Again, we can't really use this kind of information per se to predict whether a child will get a diagnosis. It was nice that a few years later, another study that focused on longitudinal analysis of brain volume did replicate the findings, and this time they started earlier on. So they had a group of babies that came in when they were 6 and 9 months, and then again when they were 12 to 15 months, and then 18 to 24. And as you can tell, the infants who actually did get an autism diagnosis did show brain enlargement, but it was significantly different only after 12 months of age. But at least it's a replication, and so there is promise there. Now, more recently, this is a paper that just came out a few months ago. They also started earlier and found brain overgrowth. But what's interesting here, and this maybe is also a reflection of the fact that they have a significantly larger sample, is that the surface growth in the brain from 6 to 12 months of age actually predicted ASD diagnosis at 2 years with 8% sensitivity. So that's quite high and promising, where other numbers have been in the field. Okay, in the same study that I just mentioned earlier, in addition to the brain volume, they also looked at cerebrospinal fluid. And here, they actually found that there were significant differences, again, with the ASD showing increase or excessive cerebrospinal fluid. And this finding held across all 3 age groups. And what was also interesting is to see that they actually had another that the groups that had some developmental delays, although not a full diagnosis, were also showing some elevation, but that was not as high as the one seen in individual with autism. And I chose to show this study because this is another one where we are lucky to have replication. And in this field, when you can find replicable findings, you are like, woohoo, quite happy. And so this is actually the recent study that just came out again this year, where they used a much larger sample and they were able to replicate the same findings. And as you can tell, I mean, you can see kind of with the naked eye, at least with the picture that they chose to report in the paper, that there is quite a bit of excessive cerebrospinal fluid in the children that were diagnosed with autism. And in this work, they were actually able to relate this to behavioral measures, and they were actually able to see that it mapped to the level of severity of ASD symptoms. So if they, based on the ADOS, if they had a full diagnosis of autism, this is what their curve, so they had the most differences in cerebrospinal fluid. The children with autism that did also fall on the spectrum did have something in between the curves seen for either the high-risk babies who did not get a diagnosis or the low-risk group to begin with. So now, switching gears at this point, I've only focused on brain structure, right? Another thing that volume primarily, and then the cerebrospinal fluid, but people have also looked at white matter tracts. Here we're talking about the fibers, the bundles in the brain that connects different regions. And again, this was a paper published a few years back that shows that there were, again, significant differences between the two groups, and even some peculiar patterns where early on the kids who go on and get an autism diagnosis seems to have higher values than you would see for the kids who do not, and then these cross over with increase in age, where they don't show as steep as an increase. And there have been a number of different tracks that people have focused on, and I don't think you necessarily care about the details, but I put these slides up because, again, I wanted to highlight the tremendous variabilities at the individual levels. So every single one of these lines represent the data from one single child, and again, you can see that there is a tremendous overlap. I don't know how many of you are familiar with this, but the corpus callosum is the largest bundles of fibers that connects the two hemispheres. So studies have focused on these particular structures, and again, they found differences particularly in the genome of the corpus callosum in the anterior parts here in red when comparing both in the kids that do get a diagnosis to the low-risk control, also when comparing the children who do get a diagnosis for the high-risk group that do not, and also when comparing, and you can tell actually when comparing the high-risk babies that do not get a diagnosis, the differences are quite minimal when looking at them in comparison to the low-risk. So these are just structural studies, again, showing some alterations, but I'm always a fan of behavior, and I like to see how this translates to behavior. And so I was pleased that there have been a number of studies that actually have attempted to relate the structural morphological abnormalities to behavior. And this is one study where they looked at another section of the corpus callosum. This time we're talking about the splenium and how that relates to visual orienting in 7-month-old infants who were at risk for developing autism. And again, the details are not necessarily as important, but you can clearly see that the curves of the slopes relating the latency of the response to the stimulus that was presented on the screen to their radial diffusivity, which is just one of the measures that we use to look at structural connectivity, was quite different across the low-risk group, the at-risk group that did not develop autism, and the high risk group that did develop autism. More recently, another study focused on the corpus callosum, but this time in the genome of the corpus callosum. These are just the fibers that are, coming out from that anterior section of the corpus callosum. And this one was interesting because they found that as early as 6 months of age, altered fractional anisotropy, which is again just another big word for that index structural development of these fiber tracts, was predictive of both repetitive behaviors as well as sensory responsiveness at 24 months of age. So you again have some nice links of some of these alteration that we see with behaviors quite a bit further down the road. Again, this is just the different patterns seen with development. Okay, so so far, we have been talking about structure, and here is, I'm switching gears a little bit on you, and I'm talking about functional connectivity. So when we're talking about functional connectivity, we're no longer talking about those bundles of fibers. We're talking about different regions of the brain being connected by virtue of their patterns of co-activations. Now, when you are at rest and doing nothing, if we put you in the scanner and we just tell you to rest, your brain is really not going to shut down. There's always activation. And the brain regions that tend to kind of work together when you actually perform different tasks have their activity fluctuates in sync. So basically they have patterns of activity that it's highly coupled or correlated. And so you can use this information to kind of look at different networks that subserve a variety of different functions. So in this particular study, they focused on functional connectivity in toddlers at risk for autism, and they looked at inter-hemispheric connectivity between, their focus was actually, they looked at the entire brain, but they were particularly interested in this red region, which is the inferior frontal gyrus, as well as the superior temporal gyrus, because those are key regions involved in language processing. Okay, so what you see here is that in the control group, there was some nice coupling between the left and the right inferior frontal gyrus, as well as in between the superior temporal gyrus. The same was true also to some extent, also for the kids that did show some language delay, but not autism. But then when you're looking at the toddlers that actually did develop autism, you see that there didn't seem to be much correspondence. There wasn't as high coupling, so you don't see much red here on the right hemisphere, and also barely a little bit of blue in the superior temporal gyrus. And again, we know that these are the brain, while most people have the left hemisphere is more important for their language function, that the right also plays a significant role. So to see this lack of connectivity between the two hemispheres is not good. And indeed, they did relate these findings to behavioral measure, and lo and behold, the stronger the connectivity in the inferior frontal gyrus, this red here, between the two hemispheres, the better the language scores that the children displayed. Here, the kids with autism, you can see there is a nice slope, and it was inversely related to their symptom severity. So the less connectivity between the two the two hemispheres in the inferior frontal gyrus, the worse the communication scores on the ADAs, as well as their social scores. Okay. So now we were talking about connectivity, but we can actually look at brain activity in babies while they're sleeping in response to sensory stimulation. Even when you're asleep, it turns out your brain can process language, and we can actually elicit the full-blown network that you would see in a person when they're awake, even when they're asleep. So it's not surprised that some of the first studies that looked at this population and these young babies have used language stimuli. So here's the first study that was done in 12 to 48 months old toddlers that many of whom develop autism. did present while the baby were sleeping. They were listening to book stories that were recorded, obviously, before that. And what you see here is that the typically developing control had very nice, strong activity in the brain, in language areas in the brain, both in the right and the left. And in the autism group, you see that there is quite a bit of a reduction of involvement, particularly in the left hemisphere. And I know this is actually shown on the right, but this is just because the MRI images, they didn't flip them there in radiological convention, but you can see that there is not much happening in the left hemisphere in this group. And indeed, when they do the group comparison, you do see a significant difference there. There have been more work done on language processing. Again, this time they focused on both typically developing controls, the kids that did have autism, but what is good is that they did two things. They also had another group that just had learning disorders, other developmental disabilities, and they also had enough subject to participant to actually split their autism group in two groups, those that had good language outcome and those that had poor language outcomes. And lo and behold, if you're just like glancing at this data, you can see that in the it was in the group of kids with poor language outcome that you had the most aberrant pattern when you're looking at what it's typical, with very little activity in the left hemisphere at all. Again, you also had some abnormalities in the children with learning disabilities, but the kids with autism but good language outcome did show somewhat of a normal, it wasn't, there were significant differences, but it wasn't as bad. And when they actually parsed this data further, they were actually able to relate this to the expressive language measure that they were collected on these kids. All right. So now that kind of conclude the overview of what's out there to kind of set the stage for the work we have been doing. And so what our approach is defined by is this emphasis on very, very early development. And we started by focusing on key circuits of interest. And today I'm only going to be talking about this language networks, but there is more hopefully to come soon. And so stay tuned. So why did we focus on language? It's not just because we have seen prior studies that looked in toddlers, 2, 3, 4 years old, and we figure, well, if they show something, let's go fishing for something. We a priori felt that this was a very good strategy. Why? Well, because we know that based on the prenatal exposure to speech, babies, newborns, are already able to tell apart the language that they were exposed, the language that was basically spoken by their mothers versus languages that differ considerably for that. So like if you are a newborn and your mother spoke English, you may not be able to tell apart English from, say, Dutch, but you had no problem differentiating English from, say, Japanese, languages that are quite different. And of course, this is also something that changes over development. So over the course of the first year of life, baby becomes increasingly better, as you would suspect, at differentiating the language that it's in their environment from other languages. And so this provides a very strong rationale for focusing on the processing of early language, because way, way ahead of when babies begin to say anything that remotely sounds like a word, we know that there has been a lot of learning that has already been happening in their brain. And as I mentioned, you can actually do fMRI during natural sleep to map language function. And the beauty is that there's actually gorgeous data that was published a few years back and actually prompted me to finally decide to start working with infants that showed beautiful language maps in 2 days old infants that had not yet even left the hospital to go home. So we were quite hopeful, and we decided to pursue this. And the work that I'm going to be talking to here now today is done by one tremendous, I actually now don't like that sentence, but it applies to her, that adjective, graduate student in my lab, Tani, who's taken the lead in this work. So just as a summary, I told you that the first time we bring them in, they're 6 weeks old. At 6 months, we have the Mullen scales of early learning that provide some indexes about their verbal development. At 9 months, we also use the communicative development inventories. At 12 months, we also have we do the Mullen again, and what I guess I neglected to show here, that at 9 months we again put them in the scanner. And today I will present to you data from both time points. So we presented them with speech samples that were previously validated in behavioral research we typically develop in infants. So we knew that these stimulus can be discriminated, and they consisted of speech samples in English and Japanese. They were both recorded by mother tongue speakers of those languages. They were matched for duration, intensity, pitch amplitude, and pitch range, all kind of things that could influence, obviously, brain responses. And so while they were sleeping, they would hear, we would present different blocks they were hearing these segments alternating with periods where they would not hear any language. And lo and behold, let me show you what some of the data are that we found. So here you're looking at the low risk group. Okay, so this is our control group, babies that did not have any familiar history of autism. You see in this lighter blue, you have the responses to English segment. In purple, or magenta, I guess this is, the responses to Japanese, and then in this purple kind of color, it's the overlap between the two of them. So what should hopefully strike you by looking at this data is that there were greater responses to English than to Japanese. And I hope I didn't mess this out. I think I messed up the color label. Tani, are you here? Yeah. I did, didn't I? As I'm looking at it. Okay, so never mind. So these two have actually are flipped. I was just had to make a new legend to pick up the colors from the image, and I messed it up. Okay, so this is actually Japanese. The purple is English, and the both is, both. So what should strike you then is that you have greater activity to Japanese, okay? Because I messed that up, sorry. Now in the high risk group, that's easy, doesn't matter that I messed it up because it's actually pretty much the same. So what does that tell us? What does it tell us? It tells us that whereas the low risk group differentiated the two speech segments, and if anything showed somewhat of a novelty preferences. They realize, wait a second, this is something new I've not heard, and maybe that increased the activity level in their brains because there was a novel stimulus that they were presented with. In the high risk group, there was really no difference between how their brain processed these two different speech types. And indeed, we did compare the two groups directly, looking, and what you see in the low risk, there was significantly greater activity in response to Japanese versus English, and there was no such thing in the high risk group. So then Tani also looked at whether we could relate these patterns of brain activity collected in infants at 6 weeks of age to later language development. And indeed, we found that we can. So their responses to English at 6 weeks predicted later language development at 6 months, 12 months, and also 9 months. So what you see here is that basically it's just maps that shows that these are the regions where the stronger the activity when they were processing English, the better their receptive language scores at 6 months, the better their receptive language scores at 12 months, and then in red is like the greater the activity, and you can barely see it, but it's there. It was correlated with a greater number of words comprehended on the communicative development inventories. Okay, so this is the story at 6 weeks. What happened at 9 months? Well, let me tell you, this is what happens in the low-risk babies, and this time I did not mess it up. This time what is yellow is English, and what is blue is Japanese, and what you see is green is the combination of both. And if earlier on in the other slides, if I done it correctly, it should have jumped at you that there was greater greater activity in response to Japanese. What you see here is that there is clearly now greater responsivity to English. So now these are 9-month-old babies. They have learned quite a bit more about the language in their environment. Indeed, by 9 months, a lot of these babies have a number of words that their parents are reporting that they comprehend. They orient to their names. They may look down when the name of their dog is uttered, and they may actually even have a couple of words in their productive vocabulary. So by this time, English takes over. Processing English becomes much more salient and crucial. Okay? What happens to our high-risk group, the group that didn't seem to differentiate much, at least at the level of their brain responses between the two languages? Well, there still isn't much of a differentiation, certainly nothing in the scale that we see in the 9-month-old babies. And if anything, yes, you see a little bit of blue. There's also a little bit of yellow in the temporal pole and some other brain regions, but clearly not to the extent that we see in the low risk. And indeed, when we actually do directly compare brain responses to English and Japanese in the two groups, we see nothing in the high risk again. But in the low risk infants, we do see that greater neural responses to English than Japanese were happening, particularly in the left hemisphere, which is again the hemisphere that it's regarded as being dominant for language. The right also plays a role, but in this case, it all makes sense. And this is work that she's going to be presenting at the OHBM meetings in just a couple of months, so it's hot from the press. Not even, kind of. Is that the right expression? Okay. All right. So we looked at language activity. As much as I do have a preference for looking at functional brain development as opposed to structural, we do have another student in the lab who is actually also working on this data set, but looking at structural connectivity. And what she did, she focused on the two language tracts. So here we see these two language tracts that are called the arcuate fasciculus and the superior longitudinal fasciculus, and they are basically very important for language because they connect the frontal region. This is, I hope, clear to everybody, is your frontal lobe, although this is like a rather weird picture of the brain, and this is like the superior temporal gyres and your temporal lobe. So those are the two main regions that process language, and it makes total sense to look at their development of this specific tracts. So she ran many different analyses, but I'm going to focus here on just a few, and I don't know that you need to worry too much about all of this, but so here we're looking at the left arcuate fasciculus and the right, and again, this is the left and the right superior longitudinal fasciculus. These are the actual data points in blue, again, low risk, and in red, high risk. And while we did not find any significant differences for the arcuate fasciculus, although there was like kind of going barely in the right direction in the left, in the superior longitudinal fasciculus, we did find significant differences in both the left and the right. And given if I managed if you recall some of the findings that I highlighted earlier on, I did notice there were prior data that showed this hemispheric differences. Like there was a prior study that failed to see activity in the left hemisphere. There was this inter-hemispheric connectivity that was also off balance. So we looked at a laterality index. We kind of wanted to see to what extent the level of left lateralization could be related to outcome measures. And so we did actually see that the extent that the babies show more of a left lateralized pattern, the better their verbal score on the Mullen at 18 months. So in summary, I hope to have convinced you that there are significant differences that we can observe in both brain structure and function that could provide early markers of autism in the first years of life. Taken together, I think the data it's promising. Now, in and of itself, any one of the single measure that I've been showing you, whether it be total brain volume or corpus callosum connectivity or brain activity in response to language, in and of itself, any single measure that it may not be a best predictor. But if we couple that with behavioral data that we're also collecting, as well as with genetic data, now this brain measure may actually yield, the crucial information to actually be able to identify very early departure from neurotypical developmental trajectories, well before we actually see any overt symptomatology. And of course, the goal here is early identification, not just so that parents know what to expect, but so that we can actually enroll these children in the earliest possible interventions in order to steer their path down a more normative course and hopefully avoid the full blown onset of the disorder. Now, for those of us who are basic scientists, this is actually very stimulating work because it also may allow us to arrive at a better understanding of the mechanism, the neurobiological mechanism that are at the core of autism, and I should say of the autisms. Because as we know, when you've met one child with autism, you've met one child with autism. Right now, in terms of future direction, I think, Susan, now that I can see, but I do have a couple of minutes. Yes. So one of the approach that we are now taking on is to study several different risk groups to assess the specificity that these early markers of ASD may have. And you've seen a couple of people have started doing that. I mean, in the future work that Dr. Jesse is and I will hopefully undertake, we are going to be looking at different groups with risk like 22q deletions and TSC, in addition to familiar risk for ASD. We also, as I mentioned, want to use multiple methods and measure to assess the integrity of this different neural system to identify pathways that are altering ASD. And from one slide that was kind of an overview of the project that we have ongoing, you notice that, we're collecting MRI data, we're collecting EEG data, we're collecting eye tracking measure, and we're obviously doing clinical assessment. We are just at the beginning of putting these data together, exploring how some of the findings that I've shown you today with MRI relates to distinct pattern of EEG whether at rest or when they're also processing language, because we have another task that it's being used both when the babies are in the scanner 9 months as well as with EEG at 3, 6, 9, and 12 months of age. So it's going to be exciting to actually put these measures together. We clearly want to examine the relationship between this different measure that we have, to do so longitudinally in order to attempt to map causal pathway to symptom severity. I have to say that I agree totally with Harley when he said, maybe we shouldn't focus so much on identifying the causes. At this point, neuroimaging is it's a little bit tricky of a measure when you want to make causal statement because it's correlational in nature. However, I think that if it allows us to identify again, these markers that can actually lead to earlier intervention, I take it. I'd be happy. I don't necessarily need to say, yay, my work has been able to identify the cause or not. So that's that. And I think I'm going to end with the notion that we actually do need to conduct large-scale collaborative studies and to use multivariate data analytic approaches that are sophisticated enough to take in all of this different type of data that we have and combine it to potentially arrive at a prediction that it's that can be made on a single case basis, which is not where we are there yet, but hopefully we will be soon. And the need for large collaborative studies, I think it's obvious to everybody here, having seen the tremendous variability that we see, the heterogeneity that it's present in autism, warrants using large samples so that we can actually begin to parse that heterogeneity in order to ultimately improve or inform more targeted intervention for different subtypes of individuals with autism. With that, I'm going to acknowledge my collaborators, my trainees, the research assistant, of course, the funding agencies, all of the families that have participated in our studies, and Dr. Shefali Jeste, with whom I have been working very closely, and she's so much fun, and we miss her that she's not here with us today. And I'm happy to take some question while I leave this other cute baby up to remind you that we are still enrolling babies, and if you know of anybody who is maybe interested, either in a family where there is a child with autism or also a family with no familial risk, we are here and happy to receive any calls. Thank you.